Hey, welcome. I'm Diana Braun, founder of the Knee Zone. I am joined today by Dr. Raj Sinha, my husband.
So as Diana said, I am her husband. My name is Raj Sinha. I'm an orthopedic surgeon. I've been in practice now for 29 years. I have had the pleasure of taking care of hundreds of thousands of patients uh, over those almost 2.5, 3 decades. I've specialized in hip and knee replacement specifically, and I've also had the privilege to design hip and knee replacement devices that have been used worldwide. We estimate about 1.5 million people around the world are walking around with implants that I help to invent, create, or design. So I know a little bit about the subject. I've also been involved in a lot of the cutting edge stuff that's come about over the last 2 decades or so. I think one of the questions that we're going to talk about is something that is allegedly new, but not so new. And I'll tell you a little bit about that. You want to read
Yeah.
out the question?
Yeah. We had two questions that came in on posts before this. So we're going to answer those two first. So, do you have an opinion of robotic surgery versus traditional? Um, Judy's surgeon will do robotic, but won't do the subvastus approach. And so I would love it if you could give your opinion first on robotic versus traditional, and then we'll take the second part of that question about what's the difference really between those styles. So I know you'll
Do you mind if
jump.
I go the other way around?
Yeah, so you're going to start with,
Because it's a little bit of a history lesson.
okay,
Yeah.
all right, bring it on.
So in the late 1990s, early 2000s, that's how old I am. And I was already 5 or 6 years into practice by that point. So at that time frame, there was this real push from patients actually who were saying, look, eventually I get there. I'm really happy with my knee replacement. But man, those first 6 to 12 weeks are just torture. How do I get a better early recovery? And so from a surgical perspective, we set out to do a bunch of different things to basically get patients less pain and a quicker recovery and a more enjoyable recovery early on. So there was a group of surgeons working with a company called Zimmer in about 2000, 2001. I was part of that group where we started a whole minimally invasive surgical approach. Now, what that included was smaller incisions, of course, and then alternative methods to get into the knee compared to how we had traditionally had done it for 30 years before that. And the idea behind it was if you create less tissue damage, there'll be less pain, less swelling, less bleeding, and therefore patients will have a quicker recovery. So the traditional quote unquote surgical approach is something called a median parapatellar. Fancy word, it just basically means we make a long incision, we cut up into the tendon above the kneecap so we can slide the kneecap out of the way. Median parapatellar, that's the traditional approach. The next sort of iteration of that was something called a quadriceps sparing surgery. So in that version, we did not cut into the tendon. We stopped at the kneecap, and we had a bunch of tricks, and we designed a whole bunch of different instruments to be able to get into the knee, and that was called quadriceps sparing. Then two other versions of that was subvastus. The vastus is the quadricep muscle, and so we would actually come up underneath the muscle and cut a little bit of the capsule, which is the lining tissue around the knee, and then be able to slide the kneecap out of the way. And the other one was called the mini midvastus. So we would actually cut a little bit of the muscle instead of the tendon, and that would allow us to get into the knee. And all of those approaches were tried. We combined them with nerve blocks and regional anesthesia, which is like a spinal block, and something called multimodal pain management, which is what I briefly talked about before, which is we use multiple different medications to try to get to the pain pathways all the way from your knee to your brain and block it in multiple different areas. So we did all of that stuff, and we did comparative research between different approaches, and the upshot of all of it was the approach doesn't make one bit of difference. The most important thing is the pain management, and that has to do with the nerve blocks, the regional anesthesia, and then the multimodal and keeping ahead of your pain. And there's plenty of papers that are comparative between subvastus and traditional that show there's no difference in early recovery or late outcome. In fact, with subvastus, mini midvastus, and quad sparing, because surgeons were learning how to do that, there was actually a higher complication rate early on in the surgeon's learning curve. Now, subvastus has gotten a lot of repopularization because there's something called the Jiffy knee that's out there, which is a subvastus technique developed by a surgeon who was probably in high school when we did all this research 20 some years ago. And he's done a lot of marketing around it. And surgeons are getting a lot of patients. And there's nothing wrong with the Jiffy knee. It works fine, but it's no better or worse than a traditional approach. So my recommendation always is pick a good surgeon who has good results, who you like, who you can talk to, and let them do what they do best. Okay, so that's all of that. A very long-winded answer.
So that is Judy's part two of her question around robotic versus subvastus. And then again, it doesn't, if a surgeon does robotic, great. If they do traditional, great. What you want to know is how many cases have they done? Because the more they do successfully, the better your outcomes will be.
So the surgical robot in orthopedics started to come out in the late 1990s again, because there was another whole movement about, well, how do we get the implants to last longer? How do we make sure the implants are put in more accurately? The first version of that was something called surgical navigation. So in the late 90s, early 2000s, there was a methodology where we basically GPS for the operating room. We would put trackers in the patient's bone, and the trackers would send a signal to the computer. The computer would then give me a live action, what's going on. I would set the targets for alignment, orientation, rotation, all these technical things that we're trying to achieve for a particular patient. And then the computer would tell me how close I am to accomplishing that. So surgical navigation. So we did that for a while, almost 10 years. And the upshot of all of it was that we reduced the number of outliers, meaning the funny looking x-rays, but we didn't change the outcomes. The patient reported outcomes were exactly the same. So a tool, it helps the surgeon get a little bit more accurate, no effect for the patient. The second iteration then was robotics. And of course, all that MIS, minimally invasive stuff, pain management stuff was also happening at the same time. But the first surgical robot to hit the US for knees was the Mako robot, which came out in about 2006, 2007. I was actually the fourth surgeon, I think, in the country to start using the Mako robot, and I was doing it for partial knee replacements. So the upshot of all of my work with the robot, and by the way, using the robot is very cool. If you're into technology in the operating room, it's a very cool operation to do. But again, when you compare the robotic to the non-robotic knees, just like with the navigated knees, there was no difference. So again, the robot's a very cool tool. It gives me real-time feedback, but a surgeon who's experienced is not going to see a lot of difference with the robot. So again, getting back to the, today, if your surgeon uses a robot, great. If your surgeon doesn't use a robot, also great. Doesn't make that much of a difference.
All right, y'all. Thanks for joining us today, and we'll be again soon. Thanks.